I want to thank everyone for joining today's seminar on clinical trials and aging, which will focus on learning health system research and the provider-researcher partnerships that are central to it. So our two speakers today are Drs. Peter Coyle and Shweta Gore, both of whom are scholars funded by the Learning Health Systems Rehabilitation Research Network called LeaRRn. For those of you who aren't familiar with it, LeaRRn is one of the two training and infrastructure grants here in our Center for Long-Term Care Quality and Innovation. The other is the Impact Collaboratory, which of course many of you know very well. Dr. Linda Resnick launched LeaRRn with BU and Pitt in 2020 to fund and support learning health system rehabilitation research with the goal of increasing national capacity for this kind of work. For those of you who are not familiar with it, learning health systems research is research that's embedded in real-world healthcare systems that use data to identify problems, implement solutions, and evaluate the effectiveness of their actions. Learning health system researchers are the investigators embedded within or partnering with the health systems stakeholders to do this kind of research. So LeaRRn applies learning health system research to rehabilitation research specifically. And together with Dr. Janet Freeberger from Pitt, I co-direct LeaRRn's Scholar Program. So the Scholar Program partners rehabilitation researchers like Dr. Coyle and Gore with health systems for 12 months to prepare for research on a quality improvement project or a priority topic identified by the health system. Scholars use that year to develop a relationship with and an understanding of the health system and to formulate and begin to execute a plan to address that priority topic while developing their own learning health system research competencies. Dr. Coyle will go first. He was a scholar with UPMC's Center for Rehabilitation Services from 2021 to 22. The focus of his project was to characterize post-acute pathways for patients who survived a stroke and are discharged home, laying the groundwork for optimizing care transitions. And he'll discuss the challenges and benefits to being an embedded researcher during this project. After he presents, we'll take a question or two, but we'll hold most of the questions until after Dr. Gore presents. She is a current scholar with BMC, and she'll describe the process of getting matched with the BMC team, the challenges and successes of joining a health system as an outside collaborator, and then her research project, which focuses on BMC's interest in improving patient mobility and rehabilitation service delivery. So with that, I'm going to turn the floor over to Dr. Coyle.
So good afternoon, everybody. I'm very excited to be here and happy that Rosette asked me to present to you guys about my experience as a learning health systems visiting scholar with UPMC. So I'm going to talk a little bit about that experience today. And I just wanted to start just by giving you some background and so you can get an understanding of what my research priorities are and how they've evolved over time and how they've eventually intersected with LeaRRn. So I did my physical therapy training and my PhD in biomechanics and movement science at the University of Delaware. And the timeline is a little important here. So I was there from 2013 to 2017. And what I want to talk about to start the presentation is how my timeline has kind of evolved or how things have changed over time in parallel with how healthcare research is being done and what those priorities are that we've identified as a research community. So full disclosure, my research training is mostly in conventional clinical rehabilitation research. So that means, a traditional clinical research laboratory setting with bringing research participants in outside of the context of healthcare. So they're not patients. And we focus really on identifying impairments in older adults with low back pain, or at least my original work was identifying modifiable impairments with older adults with chronic low back pain and developing interventions. So more on the phase one kind of end of things, phase one, phase two. So that's where all of my training occurred originally in research. Yeah, and so while alongside that, that 2013 time frame, we all know that the Affordable Care Act came into enforcement around that time. And there were a lot of changes that had a lot of healthcare research implications. So not just for the care of patients, but also how we can conduct healthcare research. and the intersection between the two of them, patient care and quality improvement, implementation science, and healthcare research. So I started to get interested in that. And one of the things that really jumped out at me, as I'm sure it is for a lot of folks, is just how long the lag is from the creation or the generation of knowledge to its translation into clinical practice. So that was really important for me. And really just watching all of these all of this intervention-driven work being developed without a very strong consideration, and it's variable across researchers, obviously, but generally without a strong consideration of how that would translate into the real world. And so that got me really interested in health services research in general. And everybody should kind of keep in mind that around this time, the Institute of Medicine started to really define what a learning health system is. So Rosa did a really nice job of explaining what exactly that means to us now. But keep in mind, at the time, this is still early stages. This is not mainstream healthcare research. So we're just starting to explore these ideas. And so with that in mind, I pursued a postdoctoral fellowship that was generously funded by the Center on Health Services Training and Research, which Linda has been involved with, as well as other investigators. And they funded my postdoctoral fellowship at the University of Pittsburgh, which had a little bit more of a focus on implementation science, older adults, and community-based programs. But during that time, I also got involved with a pragmatic trial there and analyzing some of the data that really wasn't the central focus of the study, but really looking at these post-acute care pathways for stroke survivors. So that study was the COMPASS trial. And if you all are familiar with rehab science pragmatic trials, you probably heard of this one. And so what that really focused on was looking at the discharge directly from the hospital back into the community, and how do you support those patients better and get them to the resources that they need, particularly the rehabilitation resources in home health, outpatient, and in the community. And so, around this time while I'm doing this work, Christopher Forrest published a really nice paper that started to give shape to learning health systems and what it means to be a learning health systems researcher. And around 2019, AHRQ, so you guys obviously know AHRQ is a division of the NIH that focuses on health research and quality, safety, and effectiveness. And they formally adopt these competencies, and it starts to give some infrastructure to what learning health systems are. So this subdivision of health services research that has a very specific focus. And again, just to remind you, learning health systems really are defined by health systems that use their internally collected data, enmesh it with external evidence, and use that to make decisions about improving quality to deliver higher value, safer, more effective care for patients to overall improve health well-being and healthcare experience. And so right around this time, my postdoctoral fellowship ends at the University of Pittsburgh, and a lot of the LeaRRn investigators were main investigators, principal and co-investigators for the CoStar, the center. And I had heard that they were drafting this grant to come up with a center and a network that would really support the development of learning health systems research, specifically as it applies to rehabilitation research. And so they had a funding call, or a call for visiting scholars, and that proposal was eventually funded. And so my work with COMPASS led into this body of work in learning health systems for stroke survivors. And so just to reiterate here, and this is a really important point for anybody considering going into learning health systems, and particularly the LeaRRn Scholars Program. You're partnered with a healthcare system, either embedded or partnered very closely with it. And you're working for a 12-month period to start to shape and execute a project on a priority topic that's identified by the health system. And that's really important. I have it bolded and italicized here. It's really driven by what the questions of the healthcare system are. And so as scholars, we developed our relationship and started to work to understand how each healthcare system we were partnered with really operated, identified these priority areas, and how to go about solving the problems that they had. And so I was partnered with UPMC. They had a specific interest in transitions of care. And originally, when I put my application in, we were going to focus actually on multiple older adults with multiple chronic conditions and functional limitations. So this operational definition for vulnerable older adults. And over time, that had shifted a little bit from the time they put the original grant proposal in to the time that it got funded. And they wanted to refocus more on stroke. And so again, really important to be flexible in terms of the patient population that you're working with, and really center in on helping the health system tackle the priorities with their processes that they have. So I was partnered, like I said, with UPMC. For those of you who are not familiar, UPMC was previously known as University of Pittsburgh Medical Center, and it was an outgrowth of the university. Now it's become its own large entity, UPMC. It's a highly integrated health network that offers care across the continuum, so all the way from hospital-based care to ambulatory care across numerous disciplines. And they also have their own insurance plan. So you buy into their insurance services and see their providers. And specifically, I was partnered with the Centers for Rehab Services, which is the predominant therapy providing arm of UPMC. And again, they offer services across the full spectrum. They see over 500 patient visits a year, and they serve the majority of Pennsylvania from now pushing out into the eastern side, all the way to where it originated in the western side, going up into New York and partially into Ohio. So very big health system. And they wanted to focus on their post-acute care rehab services. So like I said, originally, we were looking more at older adults with multiple chronic conditions, but it shifted focus a little bit to stroke. And I'll talk a little bit about how they arrived at this particular topic. So shortly before I started working with them, Centers for Rehab Services received some alarming news from some of their internal researchers and analysts. And what they found was folks who were discharged from the CRS inpatient rehab network. So keep in mind, to go to inpatient rehab, you have to be able to benefit and tolerate from 3 hours of intensive therapy services per day, right? So these are people who need rehab in a big way. And it's safe to assume that their rehab needs don't usually end with the end of their care in the rehab network. But only 15% of those patients who were in the rehab network were actually making it to the outpatient rehab facility. Actually, a little less than 15%. And in particular, they were interested in focusing in on the stroke population because we know that physical and cognitive limitations are ubiquitous. They're completely, most stroke survivors have some form of motor impairment or cognitive limitation after the study or after their stroke. And so it's a really important patient population for them to focus on, and that's what we arrived at. And so we also know that there are well-documented problems with care transition. So the stroke population is highly variable. And so you see a very broad spectrum of severity and limitations, and folks from all walks of life with different social determinants of health. And we know that early and intense rehab is key. So that was the primary driver for focusing on this patient population. And I should say that this is not just a UPMC problem. This is a nationwide problem. So this was a nice report that came out of the CDC. And if you don't read the morbidity and mortality weekly reports, I strongly suggest that you do. I find them fascinating, and they're very, very short reads with very relevant information. But a research group with the CDC found that only about a third of patients who have of people who've sustained a stroke go on to use outpatient rehabilitation services after their stroke. And now this is all self-report, survey-based kind of work, but it appears to be a nationwide issue. So what are the opportunities for UPMC? So they want to improve the health and well-being of their patients, but this could also decrease downstream costs for the health plan in particular, who insures these folks, and it can increase revenue specifically for CRS. So it's a missed opportunity where both the rehab department and the patients can win and benefit from it. So health systems tend to want to jump immediately to applying some sort of intervention or quality. But one of the big problems that we're starting to find as learning health systems become more popular and more mainstream is that one of the big issues is a really underinvestment and overlooking of the planning phase. So in this case, what we know here is that stroke patients generally are not making it to and I apologize for not using patient-centered language first or person-centered language first. People with stroke are not making it to outpatient therapy, but we don't know where along their care pathways are they falling off. And so really that was the focus of our project. We wanted to describe these care pathways to identify where these breakdowns were occurring and potentially identify some factors that are influential in terms of care transition success. So I had this general idea of what my LeaRRn project was going to look like over time, and it was very linear originally. First, we were going to assemble our research team. We were going to clarify our aims and project direction. Then we'd get approval, then we'd get our data, and then we'd talk to some folks about our data to figure out where to go next, how to make sense of it, and so on. And so, like all good plans, there are some bumps in the road along the way. And if you are a kid of the 90s, this is a picture from Excite Bike from the Nintendo, which was one of my favorite games as a kid, but particularly relevant here. So, and I'll describe all of these bumps along the way, but it's important to keep these things in mind. And I think really important that if you're considering doing this kind of work, what are some of the things, some of the roads or bumps in the road that you're going to encounter? And I should also say that I had this very linear idea in my head, and I don't know why. Everything is cyclical and very dynamic in research and in healthcare. And there was a lot of going forward only to go back a step to refine certain things. And I want to say that first we started, I just wanted to understand the process of what it was that we were describing and what it was that we were attempting to solve within the healthcare system. And this is a process map that I had generated to help kind of guide my thinking about who I might need to collaborate with, the variables that are important, and where the project needs to go. And I highly recommend starting with something like this. This is really born out of organizational improvement, the Six Sigma, Lean, folks who are more in the industrial side of things in manufacturing. But this can really help keep your work grounded in trying to figure out where to go next. And so, like I said, it helped us identify our key stakeholders and build our advisory team. But it also helped refine some of our questions and discussion and identify the variables that were necessary for quantitative analysis. So all really important to understand and very complex. And there's a lot of data that is potentially important to look at. And this is a nice starting point for figuring out what is the priority of the data and determining whether or not the juice is worth the squeeze for different settings and data types. So we identified our team based on the settings that were involved in the care processes we were trying to improve, which is essentially the entire post-acute care spectrum. We built out our advisory team. And so our research team really was a combination of health system scientists, which was myself and my mentor, Jana Freeberger from LeaRRn. And we partnered with our clinical operations leaders. And over the presentation, you're going to see me build out this diagram a little bit more, but it's a really nice way of thinking about all of the major players and the roles that they play in learning health systems. And it's from an article by Pam Daly, I believe her name is, in 2018, and from Johns Hopkins, who does a really nice job illustrating who all is involved, who are all the key players in these processes. So we went through multiple iterative processes to refine our process map and really identify what those variables and important settings were. And what we found was that going back and forth with a lot of these clinical operations leaders, we found that within the UPMC system, very few patients move on from SNF back into the community. And so we knew that requesting data was going to be time consuming. So we just decided that that wasn't worth the squeeze. And then from there, we were able to, like I said, detect our key questions and identify the variables that we needed. And so we started to partner with the data stewards who work for UPMC, as well as the technical leaders. And sometimes this role is one and the same, depending on what organization you're working with. But we actually had two separate pieces here. We had folks that were savvy with pulling data, but not necessarily with data architecture. And it's important to get just a broad sense of all of that. And there was a lot of complexity in our data set. And this presented another challenge. We wanted to focus on several settings within the post-acute care continuum. And there are several data sources for each setting, right? So you have billing data, you have quality reporting metrics, and you have the electronic health record. And depending on what electronic health records or architecture you're using, these could all be part of the same software. These could all be stored completely differently within different systems, which was unfortunately the case at UPMC. So now we're working with several different settings who might each have their own data steward, trying to identify who the data steward is, and the data sources where each of these groups of data live. So things to consider when you're looking at this. What is the priority level of each variable, right? Because these are a lot of potential data sources and a lot of potential variables to look at. So you do have to have some understanding of what's priority 1, priority 2, priority 3, so you can make the necessary cuts. In the end, you have to be a little judicious, just like you do when designing primary data collection, and you can't collect everything. It would take far too long, and the whole point of doing this sort of work is to generate timely results for the healthcare system. It also depends on the experience of the data stewards. So for the inpatient side, we had somebody who was very experienced and had formal training in programming. On the other side of things, we had somebody who was more on the administrative side and had some experience with reporting, but it was really learning on the fly. And so that made it more difficult to get outpatient data. And honestly, we're actually still waiting on that. So that's also very important to consider. And then finally, what are the implications for regulatory approval, right? So depending on the data that you're pulling, there's different levels of approval and from different regulatory bodies that you need. And sometimes this can be particularly problematic. So for our work, we wanted dates because the sequential and temporal nature of our research questions was important. And UPMC, frankly, had a problem with sharing specific dates. It's considered protected health information. And so we had to come up with a way. What we did was we had somebody serve as an honest broker to perturb those dates to make sure that we still kept the temporal nature without actually revealing actual dates of service. So from there, once we identified who the data stewards were, then it was time to, and the data that we wanted, it was time to approach the regulatory officials. And this is probably one of the biggest recurring questions that I'm finding right now from my own work and from working with other learning health systems researchers, but grappling with the question of what is quality improvement versus what is research, because they have two different regulatory implications. Quality improvement work is more focused on improving the processes of care within a healthcare system and identifying and producing solutions that work specifically for the context of that healthcare system, whereas research is more generalizable information. And there's a lot of gray and a lot of overlap. I don't want to get into all of the specifics in this talk when it comes to one versus the other, but this is something to keep in mind early on. And we went the quality improvement route, thinking an IRB might take a little longer to get through. It might be a little bit easier from the QI side of things. And that turned out to not be the case at all. From the research end of things, there are sometimes more resources that help you with data pools and people who are more experienced that are not at your disposal, able to be collaborated with if you go the QI route. And so that was definitely one of the challenges. And so it led to some hindrances, and I'll talk about where we are now. We've obtained some of the data, more so on the inpatient side of things, but staff turnover and competing priorities with the healthcare system led to extreme delays. So that's important to keep note of. We had to reconsider, like I said, what our regulatory channel approval was going to be. There are certain resources on the data stewarding side, if you go the research route at UPMC, that don't necessarily exist on the quality improvement side of things. So now we're rethinking our approach and maybe backing out and starting at an earlier process again in a different channel. And then finally, one of the struggles I think that we all deal with is trying to identify how are we going to fund the work next. And so we're thinking K awards and small R's to kickstart the project again, but we're really still in the early processes of grappling with this really complex question. So what did we learn? Every step is dynamic. Process flow maps. I can't express enough just trying to put on paper how, in a conceptual way, the process works that you're trying to identify or trying to improve. And then things to keep in mind, again, pros and cons of QI and research designations. One is not necessarily easier or better than the other. And it's important to really have a good understanding of, with your healthcare system, what is the appropriate pathway to go down. Finally, expect lengthy timelines and delays. It happens. I know for conventional clinical research, we're used to working with small teams and pushing forward things with the approval of a small amount of people. Here, you're working with lawyers, you're working with programmers, you're working with clinical operation leaders who have different priorities. So keep all of those things in mind. Whatever you think it's going to take, double or triple that for sure. All right. So I wanted to thank you guys. I appreciate it. I'll open the floor up to a question or two, and then turn things over to Shweta, who will also give an excellent presentation.
I have a question, Pete. Yeah, and thanks so much for that really great presentation. You discussed a lot of the challenges and barriers and the timeline of becoming an embedded researcher and even getting access to data and regulatory permissions. How would you comment about the appropriateness of this kind of work versus in the stage of career versus your stage of career of an investigator?
Yeah, it's certainly a concern when you're an early stage investigator and you're talking about work that takes long periods of time to do. And there are several steps to just figure out whether or not something is viable and feasible. That's not necessarily to say that it's not doable. And with the creation of centers and larger, kind of internal funding entities like LeaRRn and CoStar, there are now pilot awards that are available to identify something that is a little bit more digestible and can start your work off. And so, it is daunting to a certain extent. But I think for every early career researcher, you do the same thing. You try to identify senior researchers whose projects you can work on to keep your productivity up while you're trying to get your own work off the ground, and take advantage of these centers that have money and are looking to fund early ideas to try to get that work off the ground in your career moving forward. Does that kind of answer your question?
Thank you.
Thank you.
Thanks so much. Why don't we transition to Shweta, and then we can have some additional questions at the end.
Thank you, Rosa. All right. Thank you, Peter, for that excellent presentation. And I should say a lot of that was resonating with me as you were talking. I I wanted to introduce myself. I'm Shweta Gore. I'm an associate professor at MGH Institute of Health Professions in Boston. As a learning health systems scholar, I am embedded at Boston Medical Center, which is the largest safety net hospital system in New England for the past year or so. And we've been working on a project to create a culture of mobility by implementing the Johns Hopkins activity and mobility promotion approach. So today I wanted to talk a little bit about my journey getting into the Learning Health Systems Scholar Program and provide an overview of the project that I have been working on. And then I also wanted to talk a little bit about the challenges and successes getting into a health system from joining as an outside collaborator. And then finally talk about some next steps in this project. So in terms of how I got into this program, I am a physical therapist by training, and I have primarily worked in acute care settings. In terms of my research interests have been primarily in the health services realm, looking at measurement of physical activity and associations of physical activity with health outcomes in individuals with chronic conditions. And as I was exploring these relationships in community dwelling populations using large survey data, I got more and more interested in looking at EMR and in the area of activity and mobility in acute care. So with my background in acute care and my previous research experiences in activity and mobility and health services research, I was looking to extend my work in this area, as well as I wanted to build some relationships with a health system that had similar interests so that I could grow into this area of EMR research. And I was definitely seeking more directed one-on-one mentorship in this area of research. And fortunately, Boston Medical Center had just partnered with LeaRRn and Johns Hopkins to implement a hospital-wide activity and mobility promotion approach within the BMC inpatient units. This was obviously extremely aligned with my interests, so I decided to apply to this program, and I got matched through LeaRRn at BMC. So as a LeaRRn scholar, I've been working with a wonderful team of clinicians and researchers. LeaRRn actually facilitated a program that matched me with a LeaRRn mentor. And so my research mentor, Dr. Mary Slavin, is from BU School of Public Health, and she's been helping me on this project. I've also been working with the clinical leadership team at BMC, including Dr. Karen Matty and Dr. Kara Schwarm, and the research team at Johns Hopkins, and the AMP mobility team there as well. So to give you a little bit of an overview of this project that I've been working on for the past year or so, some of the goals that we were looking for when I joined was, one, to actually implement this approach. So this was an activity and mobility promotion approach, which we call AMP. And the goal was to implement it hospital-wide within Boston Medical Center, and then to really evaluate the implementation. How successfully was it adopted across all units? What was the effectiveness of this implementation to improve overall patient mobility and rehab services utilization? So to talk about AMP briefly, it is a comprehensive, systematic, interprofessional solution to counter hospital patient immobility and subsequent consequences. And there's tons of research that we already know that immobility relates to all adverse consequences, everything that we can think of. And so the heart of AMP lies in guiding providers to establish a mobility goal for every patient every single day. And so the process begins with a systematic measurement of their mobility capacity using the AMPAC scale. And as probably people here know, that AMPAC is a validated measure with 6 questions ranging from 6 to 24, 6 meaning the lowest mobility capacity and 24 indicating the highest mobility capacity. So as soon as a patient is admitted to BMC, for every single day of their inpatient stay, their AMPAC is measured and recorded. And so these AMPAC scores are used to inform the appropriate daily mobility goal using the Johns Hopkins highest level of mobility scale. This scale ranges from 1 to 8, 1 being just lying in bed and 8 meaning walking to 50 feet or more. And this is basically looking at what the patient is actually doing, irrespective of what their capacity to move is. So when these two measures, the AMPAC and HLM, are put together, these constitute the mobility goal calculator. And the way this score is entered in EPIC is that as soon as the AMPAC is entered in EPIC, it automatically generates a mobility goal for the day, setting a daily target for the patient. So, for example, if the nurse assigns a score of 16 on AMPAC for a patient, then the corresponding HLM score, which is 5 or standing, becomes their mobility goal for the day, and it auto-populates in EPIC. And so then this mobility goal provides an objective metric on the expected daily mobility to be achieved for the patient. So before we started implementing AMP, we wanted to collect some baseline data to look at what is the general patient mobility? What does it look like across units in BMC? So we did this by observation, and this process is called behavior mapping. And as Peter was talking about QI and IRB, we grappled with this, went back and forth, and finally this was approved as a QI thing. So we did it hospital-wide. We used some observers, we trained them, and they observed patients across units on 2 weekend days and 2 weekdays for 8 hours every day, which were mostly 8 to 4:30 p.m. when patients are expected to be most physically active. And these observers watched every patient once every 10 minutes, repeatedly over 8 hours. And every time they watched the patient, they scored them on their highest level of mobility. And so, not surprisingly, what we found was the overall result was obviously very poor patient mobility across all floors. If you can see, the range was 1 to 3, meaning, and the average HLM score was 2.5, meaning that they were spending most of their time in bed. So to implement this AMP, we utilized 8 key implementation strategies. And our first step was to get a buy-in from hospital leadership so that they got on board with the initiative and they made it a priority project. And I was fortunate that before I joined, this first step had already, much of the work on getting buy-in from hospital leadership had already occurred. And the hospital leadership had made this a priority intervention, and they had assembled a central mobility team. And so this, I was involved towards the tail end of this process. And then the second step was to incorporate all of these 3 mobility measures into the EPIC documentation system. This was also a huge learning curve for me, and a very rapid learning curve, because as soon as I joined, I started getting questions on what do you think should be included in EPIC? What do you think the reports should look like? And coming from a health services perspective and more like other research background, this was new to me. So I was educating myself at the same time as I was educating them or helping them facilitate this process. So it was quite a bit of a learning curve. I would say then the next step was barrier mitigation, where this involved understanding perceived barriers among frontline staff. So we wanted not just rehab, but we wanted all, it was an interprofessional approach. So we wanted nurses, CNAs, physicians, everyone to be on board and everyone to be actually mobilizing the patients to the mobility goal. And so for that, we had to, we first surveyed all of the frontline staff around implementing this initiative to look at some of the barriers that they thought that they encountered or thought that would be important. And so we captured themes to address potential solutions. We did a debriefing, so we involved all the directors and leadership in this debrief meeting and to address their challenges, so that it was not just hospital leadership, but everyone on the frontline staff that got on board with this initiative. Our next project was education and training, and this was central to the success of AMP. The goal was to train all frontline staff, including nurses, CNAs, on how to score measures for these patients, how to document these measures in EPIC, and then once they see the mobility goal in EPIC, how do they safely move these patients to the mobility goal? Because they were not all rehab trained. So this required a huge undertaking. It involved both online and on-site components of education and training, followed by a competency skills checkoff. And so in order to make this more effective, we recruited mobility advocates from each unit. And these were people who could be strong voices for this mobility initiative. They served to be just-in-time resources to answer questions around scoring or documentation. And they were also direct links to nursing leadership, and they were completing our skills checkoff for everyone else. And then our next step was data feedback, reporting, and a lot of work went into generating reports in a manner that was meaningful to the staff. We engaged an EPIC report writer, and we had several meetings back and forth to discuss and fine-tune these reports. And some of the initial reports look like the ones on the left-hand side, where the green columns indicate that there was successful documentation compliance, and the red columns indicate no documentation. And then these reports were also shared with the mobility advocates to help with getting more documentation compliance. And then the figures and trends on the right-hand side is what we now share with our unit directors, nursing directors. So here, as you can see, these graphs show the daily mobility goal achievement. So for each goal level, we see whether or not the mobility goal was achieved and how many patient days these goals were achieved. And then nursing directors can actually take these data to the unit staff to hold them accountable for this project. So some of the challenges and successes, I was joining this team as an outside collaborator. Obviously, this process was not easy because some of the work had already been going on. They were already planning this. The hospital leadership was on board. And when I jumped on this project, my LeaRRn mentor, Dr. Slavin, was instrumental in connecting me with the folks at BMC and initiating those early conversations. So she introduced me with Dr. Karen Maddie, who is the Senior Director of Clinical Operations at BMC, and Dr. Kara Schwarm, who's the Director of Rehab and co-leading this work. However, after this introduction, the big challenge for me was to find a place for myself in this health system. And for an outsider, it is not easy to find a place in another health system very easily. Again, as Peter pointed out, I knew that the learning health system had identified a priority, and I was going to work on their priority topic. I knew that going into this project, but knowing it is one thing, and doing it when you're there, it's a different thing. And I say that because I had some ideas of how this project would look like. I already had some preconceived notions about these would be the research questions. This is how the project would run. And I realized that is not always that I soon realized that was not how it was going to work. I was working with a huge team of very passionate people, and there were physicians involved, there were nurses, rehab, and other people from other institutions, and there were EPIC writers and IT staff. And this was my first time working in such a big team. And everyone, as I said, was passionate about this project, and they all had their own ideas of what they wanted to see this project, how they wanted this project to run. So my first barrier was really to just try to make myself visible and heard in this group of people. And so I think the first step that I did was I started attending the mobility committee meetings. These were weekly meetings, more about organizational things, logistics of implementation. They were talking about, where should we put the signs on floor markers? Should we put it on the door? Should we put it on the floor? So not really pertaining to research a lot, but I thought that was still a great place for me to start, because just by showing up to these meetings every time, I was becoming a familiar face to the group. And then I wanted to integrate better with the health system. I was brought in as a researcher to share my research expertise. But again, this was a huge project. And when you're implementing a new intervention or approach, which is hospital-wide, there are so many multiple moving parts, so many things to consider. And, I felt sometimes that I was the only one thinking about the research end of it. And I think, as Peter mentioned, everybody wanted to jump to that ACT phase. So I was thinking, and the research end of it, because we wouldn't have had the data for a long time. So there was a long time before I could actually start doing something, like contributing something. So I felt that I was almost a bystander, and I didn't want to be that. I felt the need to integrate myself better with the organization, to make them feel like I was part of the group. And so I used my training as a physical therapist, and also the fact that I was local in Boston to my advantage. As I mentioned before, education was a key piece of implementation, and it required multiple training sessions for nurses and CNAs on safe patient handling, teaching them how to transfer a patient, teaching them how to use mobility devices. And I just decided to show up to those training sessions, and I helped them work through those transfers, because being an acute care therapist, that was easy for me. However, I would say that there were moments of frustration. I would walk out of those training sessions thinking, am I working as a physical therapist in this project? Am I an educator in this project? Am I really doing research? But I think that doing these small things, small projects involving in this, I think that immensely helped me become a member of the group and not just a bystander. I thought I was seen as someone who's actively involved in the process, and I thought that helped me immensely. And so, having said that, I wanted to share with you the current state of the project and some of the next steps. We used the 8 key implementation strategies to implement AMP, and this went live on December 15th, 2021. So all the 3 measures went live on Epic on this date. And since then, all frontline staff are expected to document the 3 measures in Epic, and also to move the patients to the mobility goal. Our next step now is to evaluate the implementation to see how well it was adopted by all units, and to explore reasons for varying adoption, and then to look at the effectiveness of the implementation on outcomes. Obviously, this is a work in progress. our first step was to access patient level data for the research project, and so was IRB. IRB was a very challenging process because multiple institutions were involved. It was Johns Hopkins, BMC, Boston University, Mass General Institute of Health Professions, and there was just a lot of chaos around whether it's QI or IRB, but finally our IRB was approved. We also applied for the LeaRRn pilot grant for this, and we were recently funded for this project. So for the next 2 years, we will be working on these research questions. Currently, the data request is in process. So the clinical data warehouse at BU is going to help us pull data from EPIC. And we're working on the qualitative aspects of the project with the Center of Improvement and Innovation Sciences. Our next steps are we're waiting for data, and we're hoping that we get the data by the end of this year. And then we will start data cleaning and analysis. So I hope to share the results of our research soon with you all. And with that, I'm happy to take any questions.
Thank you, Shweta and Pete. And invite Pete to turn his camera back on, and Linda too, if you have any additional questions to ask. Any questions from the group? Opening the floor up for anyone.
Can you talk a little bit about what the metrics for success for your projects will be? Because I think in this type of research, some of the metrics may be a little different than what we're used to in traditional academic research that's divorced out of health systems. You know, what will the health system consider a metric of success, and is that harmonious with your metric of success?
I think our metric of success is to see whether the implementation was adopted by all units equally. And I think that would be like one of our main outcomes that we're looking for. But the health system, and I just had a meeting with them yesterday, and they are really wanting to look at how is this going to translate to length of stay. Like, they really want to look at those outcomes first. And I think we've grappled a lot because we've had a lot of challenges even getting nurses to do this. So we really, our success would be if we get a good documentation compliance first as the first step, and then look at whether it improved patient mobility, then look at length of stay. But yeah, obviously that is an ongoing conversation.
That's a great question, Linda. I think ultimately, the two things that the healthcare system would love to see, well, CRS would love to see more referrals to outpatient rehab services and utilization of outpatient rehab services for folks who have survived a stroke. I think ultimately the healthcare system would like to see decreased readmission rates, decrease utilization of more expensive services like inpatient rehab or home health, if we can move folks faster to outpatient services. And then, as Shweta had said, we also have our own milestones that are specific for this project. Obtaining a full data set is my first, I think my team's first goal in terms of doing that. And then from there, identifying what is probably going to be the most fruitful place to focus our efforts in diverting patient flow to outpatient, identifying when that's most appropriate, and identifying folks who are not currently just not being referred at all.
Megan, did you have a question?
No, I was just happy to hear those responses. I do actually, I see the comment in the chat, and I'm actually eager to hear on that one, so I'll turn it over to you all.
Okay. So that question is if and how you see your continuing partnership with your health systems beyond the LeaRRn Scholar. And I know, Shweta, you started to talk about that as well.
Yeah, that's a great question. I mean, right now with the pilot funding, I'll be working with the health system for 2 years. The three research questions that I identified for the pilot grant, I think that's like my focus, but the health system, the folks there, they've already started saying, like, can we also look at this? Can we also look at like 1, 2, 3? So I don't know how, like, hopefully there is a funding mechanism that we can look at to start answering those questions. The other thing, I think that it's Boston Medical Center is unique in the way that I don't know if all health systems are similar, because MGH is a very self-sustained system with a lot of researchers. They have their own system of researchers, and this is very different than Boston Medical Center, where I am joining in the project as the only researcher in the group, with Mary as the LeaRRn mentor, but not a lot of researchers. So they've mentioned that they would love to have me if I would be available. So I think that but we've not really had any formal conversations, but I feel like there are a lot of opportunities there.
Thank you. I know we're right at the hour, so Pete, maybe we'll give you the last word and your chance to answer, and then we can close and thank everyone for joining.
Yeah. So, Sama, that's a great question. Yes, the short answer is yes. I do plan to continue my partnership with UPMC, and as Shweta had alluded to, and I briefly mentioned in my presentation, I think it's all about finding the funding, the protected time, the resources to be able to do that. I think we have a good idea of what the research question is, and there are a few other not tangential, but related overlapping research questions, and we are trying to decide what is the best funding mechanism for that, and how do you shape the project goals for the call that's out there. And I will say that what we're looking at is using the K award mechanism might be the best way to move forward with this at this point.
I'll close by thanking you both and everyone for joining us. Appreciate your talks, and we certainly learned a lot.
Thanks for coming, everybody.
Thank you.